Hi everyone, my name is Jacob Swartz. I'm a child and adolescent psychiatrist, and today we're going to be trying to cover a big topic, best practices in psychiatric medication. And since that's kind of a big overarching topic, I thought it would be a little bit more digestible and better, and quite frankly, tough to do in 10 minutes otherwise, to kind of examine some of these principles through a specific lens of major depressive disorder. My kind of goals for this talk is us walking through making sure we are matching treatment with the severity or phase if it's an episodic disorder. Some of the ins and outs for monitoring for response, which can be pretty difficult. And there's a lot of times different tools or people we look for responses. And then a couple of discussion points in terms of, what we do when treatment fails or treatment fails because there's resistance, and some approaches to that. So first, just again for depression, when we're examining this, I'm going to kind of take us through the American Academy of Child and Adolescent Psychiatry's practice guidelines. And basically, once we've fully established this diagnosis, which again, they recommend doing with a clinical interview as well as using some screens and scales if applicable, is to really kind of get an idea of the severity, and it's through that severity we match. So for instance, if it's a very mild level, you may be able to just do some supportive discussions, decreasing stress, looking at sleep, appetite, maybe some brief behavioral activation discussions. But it's once we get to moderate that we really have to start looking at treatment. And again, when we get to moderate, or maybe if it's mild and it's enough that the client's asking for some more help, we should first offer therapy. The most evidence-based therapies that we have, especially for children and adolescents in this realm, is cognitive behavioral therapy and interpersonal therapy, but that is not necessarily the only therapies that are effective. And then if we're not able to provide therapy, or maybe there's some resistance to that, or once we get to moderate to severe, that's when we start to look at the SSRIs. And in particular, when we get to moderate to severe level, we really should recommend both SSRIs as well as therapy in kind of combo therapy. And back to what we were talking about when we had the three talking points, the other concept is the different phases. So for instance, these are all kind of our first phase, acute phase. But it's important to communicate and recommend to the client that once we get to maintenance phase, so assuming that the SSRI is helpful, we probably should offer the SSRI alone or the combo therapy for at least 6 to 12 months after the remission, kind of allowing us to prevent relapse or recurrence. Now, when we're looking at first-line agents, you'll notice I skipped over one little line from the last slide in which it said Prozac is preferred. This is a bit more controversial. Again, so that's ACAP's recommendation, but I just want to note that there's no real strong evidence base to suggest that any particular SSRI agent is more effective than any other for pediatric depression. However, Prozac has the most evidence based on a lot of the big trials from NIH and IMH, and can often be a good place to start. The three big ones we consider are Zoloft or sertraline, Prozac or fluoxetine, and then Lexapro or escitalopram. And you'll notice there's a bit of a FDA approval where it just says OCD for Zoloft or sertraline. But again, this comes from some of our more evidence-based trials that aren't necessarily seeking FDA approval. One thing I would like to point out for this that will come up in later discussion points when we're trying to figure out, like, is this true treatment resistance or was there an adequate trial, is, as I've highlighted, we want to make sure that we are at least in the generally effective dose range. So if we're going to start one of these medications, we often start at a lower dose for tolerability, but to just make sure, at least for an adequate trial, that we've gotten into that generally effective dose range. All right, so now we've started our med, we're in there. Now we're trying to figure out, how do we know if there's been an improvement? How do we know if there's been a good response? In general, the definition seems to be kind of that a response is about a 50% decrease in symptoms, and this generally holds for most of the different scales or screens. However, when we start to get into depression, especially for the adolescents, probably the most widely used, especially in the primary care realm, is going to be the PHQ-9A or the PHQ-9 adapted for adolescents. And in that one, again, the response 50% decrease. Remission would be considered a total score of less than 5. And importantly, there was actually a further look into, because just because we haven't gotten necessarily a 50% decrease, what would be considered a reliable clinical indicator? So how much of a drop would we consider as like a reliable showing that there's an improvement? And there was a study showing that seems to be around 7. So even, for instance, if they had a score of 21 and it dropped to 14, so not a full response with 50% decrease, but that does show that there was a reliable clinical response. And an important thing I want to also highlight is that there can be some differences between child and parent subjective experience. So for instance, in anxiety, there's not really been a change. But however, with depression, there does seem to be a little bit of a lag in that subjective feeling of improvement and neurovegetative and affect changes. So a lot of times, parents may notice an improvement before the child does. So it's important to get both perspectives if possible. So we've tracked about like when we would kind of see this, or how we would kind of see this response. How about when we would see this? And again, I'm having anxiety and depression on the screen just to kind of show you, even with SSRIs, there we often talk about at least 4 weeks or 4 to 6 weeks. There actually seems to be some difference, especially if we're looking for the quote unquote response, that 50% reduction, where we look in these big trials. So for instance, these are the big NIH and IMH trials. For the depression on the right, it does seem to be that response starting around week 6. However, if it's anxiety response, it can take a little bit longer to get that full 50% reduction. So you may need to stay in it for a little bit longer before we consider either a failed trial or not quite getting that response. All right, so we've done that, we've gotten through, and now what do we do when it doesn't quite go well when we start our first month? So first, what do we do when there's difficulties with toleration? So the first thing I did want to touch base, is not quite here necessarily, but I wanted to make sure we talked a little bit about the black box warning, because that is something that is difficult and kind of going through. So I'm not going to go into the full details here on what we do, but I just wanted to point out that we know this is a low apparent overall risk, and that there's a lot of controversy on how specific this risk is, but it's going to be something your patients and parents are going to be nervous about. And even with this black box warning, just a reminder that the FDA is recommending our response is not to not give this medication, but just that there's daily observation by families and caregivers. So this would be just coaching the parents, just to ask about suicidal ideation and how they're doing daily. And then this frequent contact with a physician, which there's a little bit more leeway, but it seems to be maybe like a letting the office know at least once a week how they're doing, and then trying to maybe follow up, in a couple of weeks afterwards or monthly afterwards. And obviously if there's an issue, to seek emergency help or stop the medication and then address. All right, so that's the black box warning. So what about, other than that, which of course, if we get to the point where we're having suicidal thoughts, that's a different story we have to do. How about when there's other things like medication-induced, for instance, behavioral agitation, that activation that we talk about, which can be kind of scary and kind of frightening because, it makes us go, oh my gosh, are they becoming manic? There's other elements. And, I just wanted to talk about that a little bit, and that it seems to be, this is more what we're talking about, like there's motor and mental restlessness, maybe some insomnia and some impulsiveness, maybe even some like disinhibited behavior. It's not necessarily mania. This does tend to happen more commonly in younger children. It does seem to have some relation with dose increases or high increased dose. So what we would recommend on this instance is, potentially like kind of pausing or maybe stopping, and then slowing down the up titration, slowing down the up increase, maybe going down to lower levels and see if this resolves. Not too dissimilar to the nausea, vomiting, diarrhea, those kind of activation. If it's really severe, just kind of keeping in mind that there might be something in which there's a higher dose that the person is experiencing or able to tolerate. So we might either need to slow down the titration, or as we'll see on the other slide, we might need to consider that there might be something with that patient's genetics in their liver that is making them having a more difficult time to tolerate. And so in particular, if you're noticing some of these side effects that at particularly lower doses, or even if we're going slow on the up titration, it may be worth considering the liver enzymes and the cytochrome. So for instance, those three big SSRIs that we talked about to start, so that would be Lexapro or escitalopram, Zoloft, and fluoxetine. We do know that 2C19 tends to do the metabolization for Lexapro and Zoloft, whereas 2D6 tends to do more for the fluoxetine, the Prozac. So for instance, if they were having trouble with Prozac, even seemingly lower doses, this might educate us to try to do a 2C19 SSRI for the next trial, or vice versa. All right, so let's say we got through it, they were able to tolerate it, and we got an adequate trial. So we got to that dose we wanted, and for the time period we wanted, that 4 or 5, 6 weeks, or 6 to 8 weeks if we're thinking anxiety, which is a little bit out of the scope. Now what do we do? Well, the first and probably most important thing is to do a little bit of a reassessment. Did we get the correct diagnosis? Are we missing something underlying, like a borderline personality traits or diagnosis that might need to be a different type of therapy, or a different type of treatment approach? Are we missing a chronic stressor? Is there either a trauma or bullying or some other aspect that therapy and medication may not be sufficient to overcome? And the other part that can be fairly difficult is assessing that therapy. So if we're in the combination therapy, talking with the patient, are they getting along with their therapist? Are they doing the type of therapy that we hope for? Is that a good fit? If they're doing CBT, that can often mean there's a lot of homework or extra steps outside of the therapy that the patient needs to be doing. Is that a poor fit? Are they actually doing those steps? And is that something we need to try to rectify? So let's say we've done that, we have the proper diagnosis, we've got what we needed to do, it's just not working. Here the first steps is to switch to a new SSRI. Again, my recommendation might be to consider, if possible, doing a one that's out of the liver enzyme block. So if it's one that does the 2C19, so if it's a Lexapro or a Zoloft, to try Prozac, and vice versa. And making sure we get to a high enough dose. This time, maybe we need to try, and even, although we were in the adequate dose, maybe we have to get to the higher end and do a trial on a maximal tolerated dose. And an important one that's really difficult is just understanding that there's probably a lot of frustration that the family and the patient are feeling, and try to maintain hope, and talk. We have these other treatments, we have other options. We're going to be in there with them. All right. Sometimes we have to try hope for ourselves. Now we're at the point 2 trials failed. It gets a little bit trickier. It's not necessarily like, hey, let's try that third SSRI. At this point, we have to start branching out a little bit, where there's not quite as much evidence, unfortunately, in the pediatric realm. So the evidence seems to be, we're stuck at this partial response. So we go back to, maybe we get a score of 7 drop, or we get a little bit of a partial response. Maybe we try to augment with another agent. This is, again, a little bit more of a evidence that we've seen be effective in adults, but not as much in the way of trials for kids. Or at this time, do we try an entirely different agent that's more of the alternative? So, an SNRI, Wellbutrin or bupropion, or Remeron or mirtazapine. But as you can see here, we've presented a table kind of listing some of the evidence, and it gets kind of tricky, right? All these things have this level C, which is, there's some evidence, some case trials, maybe some trials, but it's still kind of clinical expertise on the recommendations. One thing that gives us a little bit more pause is sometimes duloxetine, because we have the FDA recommendation for GAD. But a lot of times, we're getting a little bit more into, the wilderness, so to speak. But it's important we try something other than an SSRI. Kind of that adult augmentation evidence that we were talking about. So this is when we have like that partial response. These are some of the options we have out there. So we can try that Wellbutrin either as a standalone or as an augmenting agent. But then, we can try just like we would for adults, a low dose atypical antipsychotic, lithium, and there's some evidence, in adults where we start getting the thyroid hormone and some of these other ones, and even psychostimulants if needed. But I would say we probably stick a little bit more into this realm and then Wellbutrin. And then, man, just does not work. None of the medications work. Just like for adults, there's ECT or TMS or even ketamine where there's strong evidence. There's not those trials or that evidence quite yet in kids, but that still doesn't mean that we don't have this as a potential option. And if we're still just really struggling to get a response, I just don't want us to forget that these options, although a little bit more significant and intense, and probably less likely for primary care to themselves recommend, these are still options that we can try to help alleviate the suffering. All right, so we went through all of that in this discussion, and again, I just want to highlight those three kind of elements, those core elements with this that we went through with the depression. So making sure we're matching treatment with the severity or the phase that the patient is experiencing, so we're not either under-treating or potentially over-treating. Making sure we're adequately monitoring for a response, so we can know when we either need to up-titrate or try an alternative response, or making sure we don't cut off our trial too early. And then particularly if we have treatment failures or resistance, that we go back. Do we have the correct diagnosis? Are we missing a stressor? If there's an issue with toleration, can we try a different approach, either with a different liver enzyme type medication, or trying to go slower with our up titration on a slower schedule? And that once we get to some of the more significant resistant approaches, we start to step away where there's robust evidence for pediatrics population, and we might need to rely on some of the adult studies to help alleviate suffering. All right, so here are my resources, and if you have any questions, please reach out, and I'm happy to help share.